Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. So, a very interesting case. Patient attended with bilateral fully occluding earwax. We're just in the right ear. This is the patient's worst ear. And they've been oiling this ear, so they've been pre-softening it using some olive oil spray. And you can see we're making good progress here. The wax was extending right from the entrance all the way to the eardrum. And we're probably about halfway into the ear canal now. At this stage, it does get a bit impacted. And also, sometimes you run the risk of over-oiling the ear. And when a patient over-oils the ear, the wax just becomes too stodgy, too sticky, and it doesn't really suction. You can see here it's a bit sticky. It's not really getting a good suction grip. It sounds almost like a piece of chewing gum. It's very stodgy and heavy, hard to vacuum. And what I'm going to do in a moment, you can see it's just blocked the suction tube there. I was giving it a little wriggle, trying to unblock it. So what I've decided to do in a moment, I'm going to install some olive oil spray. And whilst it's dosed in the ear, I'm also going to suction. So just fill up the ear, ask the patient to gently tilt the head to the side. And what I want to do first, I just want to suction this olive oil. Otherwise, it can get a bit too blurry. You can see what the olive oil has done. It's just binded this gooey wax together and it's come out in a big chunk. Now there is some residual wax, and you'll see at the top part of the eardrum there's a white mass there. So the first objective is just to clear this wax anteriorly, so to the right hand side of the eardrum. This wax is impacted, it's in the anterior recess. I'm just using a fine end gauge. So this is in the inferior recess at the moment, actually. It's just got a piece of wax out there. Just stretching the ear open. You can just see how impacted it is. One of the analogies I use with patients is almost like when you have wet mud or plaster and you slap it on a wall. Exactly what the wax is doing against the eardrums. You can see just how large. It's quite a deceiving piece of wax there. So we're just going to mop up just some wax there at the base. Now, that white mass, what is it? It could be several things. Now, whenever it's in the attic regions, the top part of the eardrum, we've always got to be a bit cautious. We want to just rule out a potential cholesteatoma, which can be very serious and life-threatening. And I shared this video with my ENT colleague, Mr Rajali, and it could be several things. It could be a tympanosclerotic plaque. So tympanosclerosis is scar tissue. It's a buildup of calcium deposits. It's secondary to trauma to the ear, whether it be barotrauma, so pressure change, acoustic trauma, so being exposed to loud sounds, physical trauma, so physical injury to the ear canal or the eardrum, or ear infections or possible surgery. But it could also be a buildup of keratin, dead skin, and when dead skin builds up we call that region the posterior superior quadrant. We can get an attic retraction, so where the eardrum itself gets sucked in the top, creates a pocket, and dead skin that would normally migrate collects in there, and it forms a cholesteatoma. And a cholesteatoma can be quite serious. It can grow into the middle ear and grow upwards towards the brain. It can cause meningitis or brain abscess. In the worst case scenario, it can be life-threatening. So we're just going to send that for an ENT review. Going to need to go under a CT scan just to rule out any sinister pathologies. So this is the left ear. The wax is, the patient hadn't been using drops this side, so it's a bit firmer, a bit tougher, adhered to the back part of the ear canal. You saw it before, I just used an ear hook just to facilitate the removal, so the suction, because it's quite stodgy, it was a bit difficult, so I just used an ear hook, prized out a lot of the lateral earwax, gone back in with microsuction. You can see how dark that is. It's been there for a while. It's oxidized. Managed to elevate it off the posterior canal wall and slowly bring it forwards. The patient's ear canal's clear as such, so they can hear now. This residual wax isn't really going to improve. By removing it, it's not necessarily going to improve one's hearing, but we're in there. Let's just get this out as much as we can safely without causing undue potential trauma to the patient. So I'm just suctioning there. The patient was a bit unsteady at times, so I remember this patient, it's a bit unsteady. Just had to be a bit a bit more cautious than usual. We're always cautious, obviously. If you've been watching my channel and videos, you know that. So just using a fine end gauge, you can see him just tentatively just probing towards the wax, ready to move out if the patient makes a sudden movement. Just some wax superiorly. It's just gently peeling this off the roof of the ear canal. It comes out in a nice big blob. There is some dead keratin on the anterior canal walls to the front. We're going to leave that there. So we're going to make this ENT referral for this patient, to have a close examination of their right ear. It's getting some dead skin, as I said before. Just going to leave that there. It's not ready to be removed. It's not causing any problems. Just going to position that down again. It'll naturally shed. It's on its way out, and that's the function of the skin in the ear canal. As it dies and sheds, it naturally migrates outwards. Lovely healthy eardrum. And we've just got some close-ups, some zoom images of some of the wax that we removed. See, this is probably from the right ear. It's a bit wet. This is more from the left side. It's a bit dry and darker on this side. Some big pieces. So I hope you enjoyed that video, guys, and you're all keeping well and safe. Take care. Speak to you soon.